Our final presenter for the day is Dr. Cynthia Miller, and she's a clinician at Nebraska Mental Health Centers, and she's going to provide information on some risk factors in suicide ideation, and she's also going to talk about how educators and parents can provide a safe and supportive environment when a student has been identified at risk of committing self-harm, and how to respond to the surviving community following a suicide without a contagion effect. So please welcome Dr. Miller.
Thank you. Hi, thank you so much for having me here today. I really appreciate the invitation. The agency I work with, Nebraska Mental Health, has been involved with the SCIP program for quite some time now. It's really, I think, an exemplary program for providing students with assistance when they've been identified as being at risk for some sort of mental health disorder. So I really applaud the Lincoln area and the staff at the SCIP program for providing the services that they do and helping to normalize the experience of mental health. So you do a really nice job, and we really appreciate the opportunity to be involved in this sort of a project today. So thank you for having us. You want me to start all over again? Okay. All right. And I apologize, I've been battling a sore throat all week, so if you can't hear me, just wave real big. We don't have to be fancy around here, okay? I used to teach college freshmen, and let me tell you, you guys are going to be a much better behaved group than they ever were. So we'll be fun. Just let me know what you need. All right, just a little bit of background about myself. I am a doctoral level psychologist. I got my doctorate at Marshall University in Huntington, West Virginia in clinical psychology. The program that I came from was designed to provide mental health practitioners in rural and underserved areas of the country. There's lots of areas that don't have a lot of access to mental health care. Nebraska is one of those states because of the sparse population in some areas throughout the state. So it's really important to be able to have these type of outreach programs, to have people on the ground in the schools and out in the community that are able to help watch for some of these issues. So it's a very important part of providing a whole range of protective factors around these kids to make sure that they can stay safe. So I guess we're ready to go. A lot of the material that I've put together, trying to think ahead of time about what would be important from a clinical perspective, has been covered in a lot of detail already today, and people have done a really amazing job in covering some of that. So I'm going to go a little bit rogue. I hope y'all don't mind. I'm going to kind of veer from my presentation to maybe fill in a few gaps and some other pieces. We'll review a little bit because they're all important points, but I'm going to try and fill in a few places where maybe we need a little more information, if that's okay. So, a lot of parents in particular hate the thought that a child or an adolescent could ever commit self-harm. But unfortunately, it's very true, it does happen. And it happens in numbers that are far too great. So it's a very real problem. It's a problem that needs to be addressed, and we need to not be afraid. I've been fortunate enough in my academic career to have studied under Dr. Tom Ellis. He's an internationally published author on suicidology, and I actually had the privilege of working with Dr. Ellis for a whole semester on a course specific to suicide. Prior to the course, I was always very hesitant to even broach the topic of self-harm or suicide. And I think a lot of people are, because we have that fear that if I say, "Are you planning on hurting yourself?" I might give you that idea. That might have been the thing that caused you to go do that. And I was able to gain that confidence that that's not the case. You don't have to be afraid to ask that question. In fact, people want you to ask that question. Suicide is not an act of a rational person. there's some sort of underlying mental health condition, and they are reaching out for help. They may not know how to say it, they may not know how to go about it, but they need your help. They need you to ask that question. Oftentimes, particularly if you're working with a very oppositional adolescent or a very defiant teenager, when you ask that question, you may get an initial no. I'm not going to do that. Don't stop there. What we know about depression and other mood disorders in children and adolescents is frequently they exhibit more irritability, more moodiness, okay? Just because they're cranky doesn't mean they're not depressed. They're the same thing in adolescence at times, okay? So don't be afraid to keep pushing. You can do it in a really supportive and empathic way, though. Because if you push too hard, if you push too directly, they may shut down. But you can try to engage them in ways to see if they're forward thinking. You know, are they making plans for tomorrow, for next week, for next month, for the rest of their life? Are they thinking about going to college? Are they talking about those kind of things? If they're not thinking about their future, then you know you have a problem. And that's not a problem to ignore. We all make plans and consider our plans for the future. And if a child or adolescent isn't doing that, that's a huge red flag, okay? And it needs to be taken very seriously. So that's an indirect kind of way that you can find out what's really going on with that child if you believe that they're not being forthright with you. All right. So I'm way off topic here. We can probably go past this. We do know that there tends to be what we call a bimodal distribution of age spikes in suicide. They both of these spikes tend to occur in in times of life when there's great transition and great change. The first one we see adolescent suicide, adolescent teenage suicide, we see a big spike, and then again at what's typical retirement age. And again, when you think about the life transitions that go on at both of those periods of time, that's why we expect to see those changes. All right, so I'm going to hit these really fast because these are general risk factors for anyone that you may encounter. If someone has a diagnosable mental illness, absolutely, that's a risk factor. 90% of all completed suicide attempts have had some form of a depressive or mood disorder diagnosis. Okay, so 90%. There's other disorders as well, though, that go along with this. We talk so much about depression and suicide, but as we'll talk just a bit more later on, in adolescence, we need to be looking at things like ADHD as a predictor of suicide, particularly in boys. That may not make a lot of sense on the surface, but what is one of the biggest symptoms, signs that we see in boys with ADHD? They're very impulsive. Being impulsive puts you at higher risk for suicide. Unfortunately, a lot of young men with ADHD are also maybe not the best in school. They may have a lot of academic failures because of their disorder. Those repeated academic failures can also place that adolescent at risk. So we need to think a little bit outside the box. We can't think just about a traditional diagnosis of depression as being an indicator. When we think about substance abuse, alcohol or substance abuse, we need to consider those. Again, we see that tie into some of the impulsivity. With increased substance use, you lower your inhibition. You reduce that amount of risk that you may feel like is potentially there in the environment, and so you act in a more impulsive way. So particularly in the self-harm suicides, this may be an indicator when we see a lot of substance abuse. When someone maybe doesn't have the intent to die, but I'm seeing some puzzled faces, but more the self-mutilation. Those can actually escalate into suicide completions. So we can see those tying in with the substance use and abuse. If someone has made a previous suicide attempt, again, that is a huge indicator. Individuals that have previously attempted suicide, and some studies indicate that they have 18 times higher the risk of actually completing a suicide at some point in the future. So it's really important to pay attention to that. Now, I've listed genetic predisposition, and there is a lot of controversy about whether some of these risk factors are genetically based. We know that a lot of mental health problems are genetically based. There are also environmental influences. A lot of it is very learned behavior in respect of, I have a new stressor in my life, and how am I going to respond to that? If they have observed others in their families respond with some sort of a negative coping style, that's likely going to be a learned influence. And so genetic, environmental, learned, at the end of the day, it all comes down to we see when these things are close to home, we're going to see those behaviors continue. We touched on impulsivity. Impulsivity and gender are very closely related. Females will attempt suicide at a much higher rate than males. Unfortunately, males will complete more often, and that is typically based in the means or the method that is chosen for that attempt. Females tend to choose means that are not as immediately destructive, where there's time for some kind of an intervention to occur, someone that can be called, paramedics, whatever. Males, because of that higher likelihood of impulsivity, typically choose more lethal means. And so we see, unfortunately, higher rates of completed suicides. Age, I talked about that just a little bit. We see the increase right around the time of puberty, and then again more towards retirement years. Significant identified losses. We think about losses, and we think about, from our own perspective, what is a loss? And each one of us are going to identify a loss in a different way. So just because your 15-year-old student in your chemistry class, broke up with their girlfriend, even though you know that life is going to go on, that they'll have other relationships, that they'll go on to live a completely normal life, they don't have that same perspective. And so we can't minimize the value to that person when there have been losses. We have to consider, too, in today's economy, what happens to family structures when the economy struggles. Families have to downsize, so oftentimes some of the first things to go are extracurricular kind of things. Maybe now both parents are having to work full time, so we don't have a ride to, basketball practice or whatever, so that has to go. Those are losses. Those are significant social losses. And we may not think about them like that. There's lots of status with that, too. If now you're a kid that's having to get free lunches, you may feel stigmatized because that's a change. So we have to remember, it's not a loss as we perceive it, it's that child's loss and that child's perception of loss. I'm going to skip down to physical illness and then come back to hopelessness. Physical illness is actually more of a risk factor as you get older. One of the highest rates of suicide that you'll see are single Caucasian males in rural environments that own firearms that are chronically ill. I mean, those are just the statistics. So fortunately, that doesn't fit a lot of adolescents, but it is a risk factor just generally. Okay, we're going to talk about hopelessness. Hopelessness is the largest predictor of suicidality. Okay? We can bear, as kind of a human being, a human race, we can bear great amounts of tragedy. We can endure a lot of struggle in our lives, as long as we believe in our hearts that it is going to get better, that we can wake up tomorrow, that we can wake up next year, and that life will be normal, life will be better, however you want to phrase it. The important thing is, though, we feel like we have hope that we can go on. When you lose hope, or if a child has lost hope, you have to act immediately, okay? Because without hope, there's nothing else for them to hang on to. If we don't have hope that things are going to be good tomorrow, why continue? And so that element of hopelessness needs to be considered, okay? And so as part of asking that question, do you plan to harm yourself? Have you thought about killing yourself? You know, if they say yes, you say, tell me about it. You know, what's going on? And ask them, you know, what are the things that they've stayed here for so long for? What are the things that have kept them here today? And then find out how you can turn that. I mean, you got to think quick sometimes, but as a first maybe point of contact for some of these kids in the school system, be on your toes. Think, how can I get some hope and attach it to something that's important to this kid? Because that's the only thing that's going to keep them here, okay? All right. Some just general observable kind of things. You know, we've talked about, unfortunately, Donna's son had made proclamations 5 different times to different people of his plan. And so he was actually very actively verbalizing what his intent was. There's nonverbal or more subtle kind of indicators that we really need to look for. Talking about or making statements of, my family would be so much better without me. You know, I cause too many problems. I'm too much of a burden. You know, those kind of thoughts, those are really very negative reflections of oneself. And so we need to think, what is the function of that behavior? What is the person telling us when they make a statement like that? Okay? Planning activities, saying goodbye, giving away prized or valued objects. Like in the play we saw at lunch today, he gave his, I don't know what, his Xbox or something away. I mean, to a teenager, that's a significant thing, okay? Stockpiling drugs, firearms, ammunition, things like that. Those are really significant indicators. When you think about drugs, if you're trying to protect your children, if you feel like your child's at risk, don't forget the Tylenol, okay? Tylenol is one of the easiest, quickest ways that a child can harm themselves in a very serious, fatal way. So it's not just the narcotics or something like that. You got to think about everything that's out there available to them. A more passive kind of behavior we may see is just an increase in reckless behavior, okay? There have been some instances where this has actually been identified as suicide by cop, where an individual will provoke law enforcement and be killed, and then later found to be unarmed. It's later determined that they actually were suicidal. They just weren't able to initiate that act themselves. But also when we see increased substance use, driving very recklessly, handling firearms very recklessly, all of those are very nonverbal kind of ways that someone is communicating. They are in a great deal of psychological pain and they need your help. They need someone to intervene for them. Okay. Okay, so we talked about right after puberty, we generally see an increase and then a slight decrease in behavior. When we see the prior attempts or self-harm, and self-harm is huge in adolescents, so we're going to talk a little bit more about that, but self-harm is a huge adolescent-specific risk factor. We need to not ignore social media, though. So much of what teenagers communicate through these days is through channels like Facebook, Twitter, through texting, YouTube, all of those media or social media kind of resources, frequently you will hear of an adolescent making suicidal gestures or statements online, hoping for an intervention, okay? So if you're a parent or an educator and you have, you're using those kind of resources, that's important for you to know and consider in terms of what you're really looking at and thinking about that content. In terms of social isolation, in your school systems, you have to be very careful about students that have been segregated or marginalized in some way. We see a much higher risk of suicidality in minority student groups. Particularly right now, they're starting to do much more research on LGBT populations. So if you have students that have identified themselves with a minority sexual orientation, you need to be very careful about what kind of treatment that student is receiving from their peers. It ties in with the bullying, and a lot of that social isolation is a result of the bullying that we see in schools. These pieces all fit together, but when you know you've got students that are marginalized in some way, for whatever reason, those are students that need some special consideration. We need to develop, and we're going to talk more about developing protective factors, but those are students that need some additional assistance in building those protective factors into their lives. Limited access to mental health care. This is probably one of my biggest frustrations as a mental health care provider. It's in this day and age, it's to me an abomination that people don't have access to health care of all kinds. And I'm not trying to get political with this, but these kids need access to mental health care. Their parents need access to mental health care, because when the families aren't healthy, the children aren't healthy. So if you have students whose families are struggling, maybe they've had a financial backset, I don't know what access you all have, as counselors and teachers to refer for financial assistance, to apply for Medicaid benefits if they're not aware of those services. And there are also agencies that provide services on a sliding scale. Okay, whatever the child needs to get, we need to make sure they have access to it. Poor problem solving and coping strategies. This again falls in line with an ADHD diagnosis. These children typically are not good problem solvers because of that diagnosis and the disorder that they experience. So we need to bolster those resources. We need to assist them in developing those problem-solving skills, we need to challenge them to build those skills. And that can be done in the classroom as well as at home. But when we have a kid with a diagnosis, that we're aware of, those are good opportunities to help that child kind of stretch beyond where they currently are and develop a really healthy set of skills. Low self-esteem, I think that's pretty commonly observed. One area that ties in very closely with low self-esteem are adolescents with eating disorders. When we see adolescents relying on very extreme or restrictive means of weight loss, we actually see there's a correlation, which just means there's an association between the two, of increased risk for suicidality, okay? So when you see your students and you can tell there's been significant extreme weight loss, you see someone that's very restrictive with their diet, or there's concerns about binging and purging, that's a student that we're going to try to wrap up with some additional protective factors. Dysfunctional parenting or a home environment or parental psychological problems. Those two, unfortunately, tie in pretty closely. And I'm sure as teachers and educators, that's frustrating for you because you're only able to do so much once the child gets to school. But this is where programs like the SCIP program are so valuable. When you identify that a student is struggling, this is a wonderful resource for you to make referrals that will maybe introduce that family to the mental health care system. And I got to tell you, mental health care practitioners aren't stupid. When we see the kid is brought in as the identified patient, we're very easily able to determine that additional services may be needed within the family, and we can make referrals for those. So the child may not be the most dysfunctional one in the family, but by getting the child in for services, we might be able to address the problem really much more effectively by involving the parents. So the last one is repeated exposure to violence. And unfortunately, if you have adolescents or teenagers that are involved in any kind of a domestic violence situation at home, even if they're not the actual recipient of the abuse, but they can merely witness the abuse, that does increase their vulnerability to suicide attempts. So again, you see how these things all fit together. These are some of the things that we may not think about. As adults, we may want to minimize these things and believe that they're not important to adolescents and teenagers, but these are some significant life changes and losses that we need to consider in thinking about what that child's life may be like at this time. So when we see those romantic breakups, I know we've all been through those, and we know that you get through those. But when you're in the midst of that and you're 12, 13, 14 years old, it doesn't seem like there's going to be a tomorrow. That was the love of your life, and they're gone. So now we have to help that child pick up the pieces. Bullying, we've talked about that. Pregnancy, that's a big factor. It's not as great a risk factor now because there's not as much stigma around pregnancy out of marriage, but it still can be an element. There can be an element of shame or guilt that we need to address. When we see a lot of conflict or dysfunction at home, parental divorce, and then that leads into one of the bigger things that we have to consider is when we see adolescents being overly parentified. When you see the oldest of the siblings actually running the show, making sure the younger kids get fed, get their baths, get their homework done, get to school, those are responsibilities of adults. And when you place those responsibilities on adolescents, it's not right. and the children know that it's not right. And so it puts an undue amount of stress and anxiety on these kids. So when you see that, when you observe one sibling in a family really playing caretaker for the rest of them, that may be that red flag that you need to make a referral for a SCIP eval. All right, lack of protective factors. I've mentioned those several times. The way that I was trained in considering suicidology or suicide is inherent within all of us. There are some risk factors to complete suicide or attempt suicide. As we face stressors, we each have developed our own coping strategies for how are we going to address those stressors that occur in our life. The theory that I was most trained under is the stress diathesis model. And that's just a fancy way of saying, as we accumulate these stressors and these disappointments and these losses in our life, we can be fairly resilient to a point. And then because of this vulnerability we may have, for whatever reason, we'll get to a point where we can't kind of deal with another stressor. And that's where we break, okay? So the idea with building these protective factors in is an attempt to try to insulate that child, develop more resiliency so that we can stretch that period of time out. We can adjust what they're capable of handling in terms of stress. You know, with more insulation, with more support, they can actually adapt better as the load of the amount of stress in their life goes up. So what kind of things do we think about when we think about protective kind of factors? These can be church groups. They can be local community rec center groups. They can be extracurricular activities. They can be anything that connects that child to a larger group of people, okay? Because remember, one of our risk factors we talked about a few minutes ago was social isolation. So to build protection in, we want to take that social isolation off the table. We got to build more stuff into their lives. So in terms of self-harm, I think one of the things that frustrates me most is that oftentimes people will minimize self-harm attempts. You'll hear statements like, well, they were just scratching themselves. You know, they didn't bleed, or, you know, it's just that minimizing. But think about the function of that behavior. What is going on that makes you want to cause pain to yourself? Okay? You can't ignore those kind of things. What research has shown us is that with each self-harm attempt, even if it starts as very superficial, they tend to escalate because you start to become desensitized to that pain. So each time you cut a little bit harder and a little bit harder, and one day you go too far and you bleed out. That's what happens with these self-harm episodes. Not a lot of times these episodes are considered to be very much just attention-seeking. And in a way that's true, and the way that you pay attention to them needs to be very important. You don't want to be overly dramatic in your response because you don't want to encourage, oh, thank you. Because you don't want to encourage other attempts like that. But at the same time, you want to communicate empathy, you want to communicate hope, and you want to communicate that there are services out there, that you will help them get those services, that you are available to help them navigate this system and get them where they need to be. So pay attention to the right thing. Don't pay attention just because there's a lot of blood. Pay attention to what is the intent of that action. Okay? And the intent is they're wanting somebody to help them. So get them the help. I think we can go on. Okay, I think I already covered that page, so we can go on. All right, so here's some more on protective factors. We want to make sure that when we're building in these protective factors, that we approach this from both sides of the mental health world. To get the best result in terms of treatment, you need not only psychological services such as therapy, but you need psychiatric services to monitor medications and make medication recommendations. Unfortunately, a lot of times people do one or the other. What research has shown us, though, is that when you combine those two treatments, you see a much greater rate of improvement. They kind of come at it from two different areas. Therapy is going to teach skills that will last a lifetime and will work in any situation. Medication more answers that immediate kind of need, that physiological need, when you have diagnoses that are related to chemical imbalances. Okay? We need to develop rational cognitions, and that's something that we do every day in therapy. We look at the thought patterns, we look at the thought processes, we look at the feelings that are generated by those automatic kind of thoughts. And we challenge those, and we work through those issues. And for every person, it's going to be different. But suicide is not a rational act. You can't understand it as a rational person. Okay? It's an irrational kind of thing. So that person's cognitions are what we have to pay attention to. So you look at those. You develop healthier ones. We talk about building that strong system of social support. And this can include the schools. It can include mental health practitioners. It can include community groups, athletic groups, church groups, mentoring groups. I mean, whatever is going to work for that child is what you can involve. And everybody can bring something different to the table. One of the other things, ways we like to challenge people in treatment is to identify areas of interest and strength. Frequently with depression, individuals will have formerly or previously really enjoyed a certain pursuit. And then as the depression takes hold, they leave that behind. We try to find ways that we can rekindle that through uses of techniques like behavioral activation. We try to put them back in touch with those things that gave them pleasure, that gave them that feeling of accomplishment and self-worth, okay? If they've never developed those things to start with, then that's where you have to start. But if they had those previously, you just get in touch with those again. You continue to build on what was already there. All right, in terms of community resources, there are lots and lots of resources. You just have to look. I'm not from Nebraska. I don't know if you could tell. But so when I got the opportunity to do the presentation, I Googled what were the resources here in the Lincoln area. I found all kinds of things. You're a very fortunate community. The first one is the National Suicide Hotline that works anywhere in the country. It's 24 hours a day. People will answer the phone and will talk to you. National Hope Line Network is a similar kind of availability. It's another national service. If it's a life or death emergency, when you call 911, you don't hesitate. It's better to err on the side of being cautious than to let someone lose their life. Lincoln also has, since I've been here, I've been introduced to the Lincoln Non-Emergency Police Line. That is a wonderful resource. These police officers have additional training and topics related to mental health. And so when they come into a situation, they're actually a little more maybe psychologically minded and are able to be really sensitive to whatever that issue may be. So that's a really valuable resource. You've also got the Nebraska Youth Suicide Prevention, the LOST team, which I guess they're here today. That's an awesome group that provides support after a suicide. You've got the State Suicide Prevention Coalition. Boys Town has a hotline. Brian West, it's where you take mental health. Okay? So if you have an adolescent in crisis and you're the one driving the car, that's where you want to go. And then you have lots of mental health practitioners locally. Now, I have a personal bias. I want you all to come to Nebraska Mental Health Centers, but, you know, that's my bias. I think we do really good work, and I'm very proud of the work that we do with the SCIP program and with individuals throughout the community. All right. In the event that a suicide occurs, you know, there's a lot of awkwardness in our society just because of it is still so stigmatized. I mean, Donna gave us a heartbreaking account of what happens when a suicide has occurred in a community. And I think people are very much at a loss as to what is the right thing to do, what is the right thing to say. There has been some research into this area, because what we don't want to have happen is to create a contagion effect, where one student in a school will commit suicide, and then you see maybe a domino kind of effect, where others will follow. So in terms of research, it's after the suicide, we've tried to look at how do we prevent that contagion effect? Because one suicide is a tragedy, but to have multiple suicides is just unconscionable. So how do we keep that from happening? The number one thing that's recommended is we don't create permanent physical memorials. And that may seem kind of harsh, because these are people that were loved by those around them. The idea is, as opposed to creating a memorial that may trigger those thoughts of immortality in other students, if I die by suicide, everyone will remember me forever because they're going to plant a tree or they're going to name a baseball stadium after me or something like that. We don't want that. The suggestion is instead, so that you can honor that individual, making monetary contributions to organizations like Donna's, or to the LOST team, or whatever community-wide resource you have to prevent future suicides. It's been found to be more effective to present information to students once a suicide has occurred in very small classroom type settings, as opposed to calling all the students to the auditorium and telling everybody at once. When we give information to the students, we don't want to give specific details. The details aren't necessary. The other thing that you're going to hear is, why did it happen? Unfortunately, most of the time we don't know why. It's not a simple answer. Suicide is a very complex interaction between biological, goodness, let's lifesaver help for a little bit. It's a very complex interaction between biological, social, and psychological states. And for every person, it's going to be different. Very few people actually leave a suicide note despite what movies and television tell us. There is such a thing as a psychological autopsy where they can go in after the fact, but it's not commonly done and it doesn't change anything anyway. So you're going to get a lot of why. Instead of focusing on the whys and the hows, what you need to focus on is there is help. Get help. And identify those resources for those kids. Talk about those warning signs. In some of the research that's been done on suicide prevention programs that are school-based, some of them have been really effective where they have incorporated student peers into those programs so that they can be kind of the liaison between the student body and the administration that actually runs those programs. So giving them resources like that and focusing on those kind of things, and then focusing on that message of hope, that it doesn't have to end like this. You know, it can be better tomorrow. It may be difficult because you don't want to sugarcoat it, but it can be done. So that's what let's see. So the one I haven't mentioned there, and the one that I'm going to take 28 minutes to talk about, is evaluating the need for mental health services for their survivors. And who are the survivors? I mean, those are the other students, you know, within that school community, and the family members, siblings, parents, grandparents. So you need to pay very close attention to what is going on, you know, within your school systems, with the group of friends that that individual spent time with. You know, are they mourning? Are they not mourning? Are they isolating themselves? Are they just an emotional wreck all the time? What's going on with them? And it's to me, it's so wonderful, and I keep talking about how great it is, but I come from a school system that did not have a SCIP program. And so I have been so amazed at the resource you have as educators with that type of a program. So when you see those kids, don't hesitate. What's the worst thing that's going to happen if you refer them for a SCIP eval? They come to my office and I tell you they're okay. I mean, it's an hour of their time, you know? I'd rather waste an hour of somebody's time and make sure there wasn't a problem than to let them walk away and maybe not be here tomorrow. So don't hesitate. I
think one of the challenges, and you guys can be wrong, is a lot of times it will be offered, but what are some suggestions when a family is experiencing or has experienced to help them see the value, to help them then seek out help? Because I think that's
right.
a challenge for the schools.
Right. Did everyone hear the question? Okay. Rose's question is, although you have that as a resource and you may make the referral, what is a way to engage that family so that they're more likely to take advantage of that service that's offered? Did everybody get that? Okay. I would address it the way that I just addressed it to you. What's the worst thing that can happen if you bring your kid to this hour-long appointment and somebody tells you they're okay? You probably take them to the doctor for a sports physical so they can play football, and you find out they're okay. Why is this any different? You know? Because a SCIP eval is not going to be generated for no reason. There's going to be something that's going to be obvious going on in the environment. And, you know, there may be some denial of a problem. There may be some minimization of that problem. There may be some concern about the parents, you know, being able to afford it financially. But again, reiterating that first visit is no charge for that evaluation, you know, may make that an easier kind of step. And I challenge people all the time to tell me what would be the disadvantage to doing this. What's the disadvantage to finding out your kid's okay? Nobody? A lot of it depends on the situation that's experienced at the school and what kind of infrastructure the school has in place already. Some schools are better equipped in terms of available mental health resources than others. But the typical response involves, making sure there's adequate mental health professionals available to students at the school, and then follow-up care is necessary. Does that answer the question? Other questions?
Okay, so have you had any cases where you dealt with, a family brought them to you and they were like, they're suicidal, they have suicidal ideation, have they ever completed suicide, like any of the clients that you have had?
The question was, have I as a therapist ever worked with patients that have expressed suicidal ideation or suicide intent, and have any of my patients ever completed suicide? I have absolutely worked with patients that have expressed suicidal attempt, that have histories of previous suicide attempts. I have been very fortunate as a mental health practitioner not to have had a patient actually commit suicide. I had a supervisor tell me years ago, though, that inevitably it will happen. It's part of what we do. But you try to do everything you can. When that's identified in a therapy setting, you immediately go into a safety planning mode. And hopefully it's at the point in your therapeutic relationship where that person feels very safe and open with you, and you're able to do some effective problem solving, develop a plan to keep them safe, and refer them on for inpatient care, if they're not able to develop that safety plan and you feel reasonably certain that they're going to be able to maintain that themselves safely. Okay. The question was, in terms of thinking about protective factors, how do people in their support system, how can they add value to that relationship? That can be done in a lot of different ways, and it depends on what those relationships are. If those can be people that in an immediate crisis kind of situation, if you're developing a safety plan, they can be part of that safety plan to help ensure that person is able to maintain themselves safely. That can be the point of contact for helping to facilitate doctor's appointments. Whatever is lacking in that individual's life, whatever protective factors we need to put in place and kind of shore up to strengthen that individual, those important identified people in their lives can add a great deal to that. This isn't the kind of thing that, as a psychologist, you try to take on all by yourself. I mean, I think if you do, you're a fool, because you can't be with that patient 24 hours a day, 7 days a week. You have to have a whole protective force around that patient, and that's going to include anybody that's willing and able to step up to the plate and be able to help that patient in a meaningful and valuable way. All right. Thank you all.